And I will move then, I think this will be quite okay to just discuss how common is periimplantitis, I mean the prevalence of periimplantitis. First to do so, I would like to give you some data from our clinic. These are just to show you. We recalled patients that had been treated by either oral surgeons or periodontists between 88 and 92. A total of close to 300 people were treated. We managed to get 218 to the clinic, and that was close to 1,000 implants. Those were treated by specialists. 1 year after therapy and placement of the superstructure, they were recalled back to the clinic, so they had been to the specialty clinic after 1 year. But then all the other supportive therapy they were given by the referring dentist. They were then recalled to the clinic, and we took 5-year follow-up with radiographs. So we made clinical and radiographic measurements. And then in this specific study, we recalled them again after 9 to 14 years. And what we did find is that, those 218 represented 71% of the total amounts of the individuals that were treated. 32 individuals had died. 53 did not want to come or were unable to come to the clinic because they were too sick. And then we took radiographs and we looked also how much bone they had lost. And we used for this a cutoff level of more or equal to 4 millimeters of bone loss to be considered as periodontitis in these patients. And then we looked how many implants were still in the mouth and how many did they lose. And we compared to if they had periodontal disease or not. And as you can see here, that these are the individuals without teeth that we were not really sure of why they had lost the teeth. This really black one here are the ones that has a bone level that more than 4 millimeters bone loss in 31 to 100% of the present teeth. So they were, as we considered, periodontitis patients, and the gray one had at less than 30% of size a bone level loss of 4 millimeters or not. So we concluded that yes, the ones that have more periodontal disease also lost more implants. These are just the individuals, and this is just to give you an idea and maybe to relate to your own patients in your own clinic. The age limit, here those patients were 65 years old as a mean age. As many men and women, no difference. And we have 37% roughly that were never smokers, about 37% that were former smokers, and only 26% that were smokers. As you can see, they had many implants, most of them. Mean number of implants were 4.6, which means that a lot of them had complete, prostheses in either the upper or lower or both. Very few had only single implants. They went to the dentist once a year, and some of them also, we could say, went to the dental hygienist. 0.6, dental hygienist visit per year. And 84% of those individuals had, a follow-up of 10 years or more. So those are the patients. If we look at those patients, we see that 2.7% of the fixtures were lost before loading and before placement of a superstructure. 0.7% of the fixtures lost were within the first year. And only 1% of the fixtures were lost between year 1 and 14. So, to conclude, the implant loss were low. So we are in the same range as everybody else. This is just to give you an idea. So we are in the same, bracket as everybody else. Implant loss 4.3%. We found that the patients with a history of periodontal disease had lost more implants. And another interesting thing from a clinical perspective is that patients that lost implants, they often lost more than one. So we found a cluster effect. So individuals that lost, well, I don't know, the internet, we don't need that, do we? The implant loss clustered within patients. And we found that smokers lost more implants, although this was not statistically significant. So, now I think the next slide is interesting because it shows an important thing. Of course, we had a survival rate of 95.6%. So we are in the range where everybody else is. But this is based on implant data, exactly as all the reports you have out there. But you don't have implants in the chair, you have patients in the chair. And if you transfer this to patient-related data, it means that 11.5% of the patients had lost one or more implants. So more than one patient out of 10 had lost one or more implants. And why am I telling you this? Yes, because this is, I think, the reality for many of us. And then when we are going to talk about presence of periimplantitis, it is on the remaining implants. First they lose some, and then on the remaining we are looking for periimplantitis. So also another interesting thing is if we look at this with periimplantitis, it could be defined in many, many different ways. This is one way that we were using. We said that periimplant mucositis is more or equal to 4 millimeters of probing depth combined with bleeding on probing and or pus, and that we have periimplantitis. This is bleeding on probing and or pus, and it should be a loss of 3 threads, which is all those were Brånemark implants. So this means it is, transferable to 1.8 millimeter loss as compared to the radiograph taken at year 1 year after loading. So 1 year after loading, you lose 3 threads, then you are classified as periimplantitis. And this is a little bit different than this, where Franson et al. Used another type of classification. They said that they selected the ones that had lost a bone, and then they saw if there was a difference of 1.5 millimeter over time, then this was considered to be periimplantitis. If they have progressive bone loss, as they decided to use the term. And they have 28% of those patients to do it. If we were using this definition, then we found in our group of patients that on a patient-based level, 16% of the patients were considered to have periimplantitis. And of course, since we have more implants, if we go on implant level, we have 6.6% of the cases with periimplantitis. Just a few other studies. This is from Norway. It's also a university clinic with Kolsland and co-workers. They had more than 100 subjects and 351 implants. They used different thresholds in defining periimplantitis. One threshold is bleeding on probing and probing depth more than 4 millimeter and a bone loss of more or equal to 2 millimeters. And the other definition is bleeding on probing and a probing depth of more than 6 millimeter and then a bone loss of more or equal to 3 millimeters. And depending now on what type of definition they use, they will also get different amounts of periimplantitis to report. In the using the shallower one with 4 millimeter and 2 millimeter bone loss, they end up with 25% periimplantitis. If they require 6 millimeter and 3 millimeter bone loss, they end up with 13% of periimplantitis. I will give you now a German study from a colleague of yours, a private practice, Sven Rinke. It's a nice study in 89 subjects. They were all treated between 1999 and 2006. The mean observation time in these individuals were 68 months. But the interesting thing here is that they really went to a very structured, supportive care program. They were recalled every 3 to 6 months to the clinic. And they were taking probing pocket depths twice a year in these individuals. If they defined periimplantitis as a probing depth of more than 5 millimeters, bleeding on probing and presence of pus or presence of pus, plus a radiographic bone loss, they end up with 11%, 11.2%. So just to give you the full picture, this is how it looks. If we look at, different studies, here you see it varies a lot, 25% from the Franson study, 16% Ross-Jansok, Kolsland, either 25 or 13, Rinke 11, Marone 2012 37, Mirmari also 2012 16. So those are the figures that we have in the literature. And at a consensus conference that were held by the EAO, we concluded, I think it was 2012 if I remember correct, it was published 2012. We concluded that, roughly after 5 to 10 years, you will have periimplantitis in the range of about 20%. This is roughly what you can expect based on the available data today. This may change, we don't know, but based on what we know for now, these seems to be what we can expect in the future. So it is not really an uncommon problem, and we will see it in our practices, quite a lot, I think, in the future. And of course, it will be very important for us to be able to find, the risk factors. What are really the risk factors for periimplantitis?